antithrombotic therapies and their laboratory assessment. So a quick overview on antithrombic drugs. So antithrombotic drugs are medications that reduce blood clot formation and are critical in preventing the treating thrombotic disorders such as venous thromboembolism and stroke. There are some major classes of antithrombotic drugs. First one is unfractionated heparin. This is a mixture of glucosaminoglycans with variable molecular weight. The mechanism is it enhances activity of antithrombin 3, inhibiting thrombin, which is factor 2A, and factor 10A. It's administered intravenously or subcutaneously. It can be used for immediate anticoagulation, often in hospital settings, and it does require monitoring of activated partial thromboplastin time, or APTT. Another one is low molecular weight heparin. This is derived from unfractionated heparin, but with smaller molecules. Preferentially, it inhibits factor 10A. It's administered subcutaneously with more predictable pharmacokinetics. It does not usually require routine lab monitoring, and this is preferred in outpatient settings and during pregnancy. Then we have direct-acting oral anticoagulants. This include direct thrombin inhibitors and factor 10A inhibitors. Oral administration for these, as the name indicates, with fixed dosing, and these do not require routine coagulation monitoring either, and it is increasingly used for stroke prevention and venous thromboembolism treatment. So, venous thromboembolism, by definition, includes deep vein thrombosis, which is DVT, and pulmonary embolisms, which are PE management. VTE is treated and prevented using the unfractionated heparin, low molecular weight heparin, and anti-acting oral anticoagulants, as well as Coumadin. Some clinical uses of antithrombotic drugs. We use it for the prevention of strokes, especially in arterial fibrillation, prevention of VTE after surgery or prolonged immobilization, in the treatment of DVT and PE, and the management of other thrombotic conditions as indicated. Arterial thrombosis refers to the formation of blood clots within arteries, leading to obstruction of blood flow. This condition causes ischemic damage to tissues supplied by the affected artery. Some clinical conditions include acute myocardial infarction, which is the blockage of coronary arteries causing heart muscle ischemia and necrosis, ischemic cerebrovascular accident or stroke, which is the sudden loss of blood supply to brain tissue causing neurological deficits, and transient ischemic attack, so temporary episode of neurological dysfunction due to transient arterial blockage. These symptoms resolve within about 24 hours. Then we have peripheral arterial occlusion or peripheral artery disease. This is where there is an obstruction of arteries supplying limbs, causing pain, ischemia, and potential tissue loss. So management of arterial thrombosis, they can give anticoagulants such as the unfractionated heparin, low molecular weight heparin, and warfarin. Can also give some antiplatelet drugs such as aspirin. So in summary, the arterial thrombosis leads to serious ischemic events like AMI, stroke, TIA, and PAD. It's managed with the combination of anticoagulants and antiplatelet agents to prevent clot formation and progression. The selection of therapy will depend on clinical scenario, risk factors, and patient characteristics. All right, so Coumadin is a vitamin K antagonist. What that means is it inhibits vitamin K epoxide reductase, reducing the regenerative of active vitamin K. Its effect is it decreases synthesis of vitamin K dependent coagulation factors and regulatory proteins. So we do have vitamin K dependent coagulation factors. So factor 2, also known as prothrombin, factor 7, factor 9, and factor 10 all require vitamin K for normal synthesis. Without vitamin K, these factors are produced in inactive forms, unable to participate in coagulation. The vitamin K dependent control proteins, as we have proteins C, S, and Z, these also depend on vitamin K. So these proteins regulate coagulation by inhibiting clot formation. Their dysfunction can alter the balance between coagulation and anticoagulation. So the role of vitamin K is it enables gamma carboxylation of specific glutamic acid residues on coagulation factors and control proteins. This modification allows them to bind calcium ions and cell membrane phospholipids. This binding is essential for proper localization and function in the coagulation cascade. So some consequences of vitamin K deficiency and antagonism: the production of non-functional coagulation factors and control proteins. It will result in impaired clot formation and anticoagulation regulation. So therapeutic use of Coumadin exploits this to prevent thrombosis. To monitor Coumadin therapy, we would run a prothrombin time, or a PT, which would also include a calculation called an International Normalized Ratio, or an INR, and this is used to monitor Coumadin effectiveness. The calculation is shown there on your slide. I would definitely know how to do that. For therapeutic INR range, this is generally between 2.0 and 3.0 for most indications. If an INR is greater than 5.0, this can indicate a high risk of bleeding or hemorrhage. So regular monitoring is essential to balance anticoagulation efficacy and bleeding risk. There are also dietary effects on Coumadin. So as mentioned earlier, vitamin K intake from diet decreases Coumadin effectiveness by promoting synthesis of vitamin K-dependent clotting factors. A high vitamin K intake can reduce the INR, which can potentially lead to under-anticoagulation. Patients should maintain a consistent vitamin K intake to avoid fluctuations. Some drug interactions that can affect Coumadin. So certain drugs suppress the vitamin K cycle, enhancing Coumadin's effect in increasing INR. An example would be like metronidazole. These can double or even triple the INR, increasing the bleeding risk. We need to closely monitor, and possible dose adjustments of Coumadin are needed when starting or stopping these medications. If we need to reverse Coumadin, so there would be some indications. So indications for reversal is if they have major bleeding or hemorrhage, urgent surgical procedures that require normal coagulation, or if they're having supratherapeutic INR with high bleeding risk. Methods of reversal is vitamin K, so this would be administered orally or intravenously. This promotes synthesis of functional vitamin K dependent clotting factors. This takes about 6 to 12 hours if given oral, and faster if it's IV, but slower than a factor replacement option. The dose will depend on the INR and the clinical situation. Can also do an FFP, or fresh frozen plasma. This provides all clotting factors immediately to the patient. It is used for rapid reversal in bleeding patients, and it requires the blood type matching and infusion of large volumes. Prothrombin complex concentrates, so the concentrated factors can be given, and this would be factors 2, 7, 9, and 10. So this is a rapid and effective reversal of anticoagulation, and this is actually preferred over the fresh frozen plasma, or FFP, for urgent reversal due to a lower volume and faster action. You can also give a recombinant factor 7A. This occasionally is used off-label in life-threatening bleeding and can act to directly activate the coagulation. For unfractionated heparin, you can also just call it heparin or unfractionated heparin. It works by an indirect and catalytic anticoagulant, and it requires an antithrombin to exert effect. Enhances the reaction between thrombin and antithrombin by acting as a molecular bridge. This accelerates the inactivation of thrombin, or factor 2, and factor 10A. Some therapeutic uses: it's administered intravenously, and it is used to treat venous thromboembolisms and provide initial treatment of acute myocardial infarctions. It can also be used to prevent reocclusion after coronary stent placement, or it could be used even to maintain vascular patency during cardiopulmonary bypass in cardiac surgery. We need to monitor heparin therapy, and the test we would use would be an activated partial thromboplastin time, or a PTT. This is kind of the traditional monitoring method for this. Another option we have now is the anti-10A heparin assay, and this measures the heparin activity more specifically. For reporting results, both tests have defined normal ranges and therapeutic ranges. So the therapeutic monitoring is going to be essential due to heparin's variable dose response. For heparin, there is no universally consistent therapeutic range yet. There is variability due to patient factors and clinical conditions. So there are limitations of heparin therapy, though. There is heparin resistance, which is a reduced response in some patients. There's influence of inflammation and prolonged unfractionated heparin use on monitoring accuracy. For monitoring heparin, we can do the chromogenic anti-10A assay, which is increasingly used for rapidly replacing the APTT. Some advantages is it has fewer interferences and has greater stability and reproducibility. It measures the activity by quantifying antithrombin 10A binding, and it reflects only the antithrombin-mediated inhibition of factor 10A. It does not reflect all plasma-based heparin activities, as PTT does. We can also do an activated clotting time, or an ACT. This is used during high-dose unfractionated heparin therapy, such as in cardiac surgeries and cardiopulmonary bypass. We can also do this as a point-of-care test, and the values typically exceed normal lab ranges due to the high heparin doses during these activities. For reversal of heparin overdose, we can use a protamine sulfate. This is actually derived from salmon sperm. It binds to unfractionated heparin and neutralizes its anticoagulant effect. It's used in cases of heparin overdose or to reverse heparin during surgeries. It may cause delayed heparin-induced thrombocytopenia, or HIT, if you remember from previous lectures, where the platelet counts need to be monitored after administration to make sure that that does not happen. For low molecular weight heparin, some characteristics is it is derived from unfractionated heparin by depolymerization. It has approximately 1/3 the molecular mass of unfractionated heparin. Primarily, this will inhibit factor 10A with less effect on thrombin. So to measure low molecular weight heparin, PTT is not useful for this. The preferred assay is the chromogenic 10A anti-10A assay. It measures the low molecular weight heparin activity by quantifying factor 10A inhibition. The mode of administration, this is administered via subcutaneous injection, and it allows outpatient or home-based therapy. Advantages of low molecular weight over unfractionated is it has a longer half-life of about 3 to 5 hours, where the unfractionated is about 60 to 90 minutes. It has a more predictable dose response, which reduces the need for routine monitoring. It can lower the risk of bleeding complications, and as mentioned earlier, it's kind of suitable for home therapy due to the ease of administration and dosing stability. For therapeutic range, the therapeutic anti-10A level will be 0.5 to 1.2 units per milliliter. All right, so pentasaccharide therapy. This is the only synthetic heparin-like anticoagulant. It is composed of a single specific molecular structure. Unlike unfractionated heparin and low molecular weight heparin, it is not a mixture of polysaccharide chains. This selectively will inhibit factor 10A via antithrombin. So mode of administration, it is given by subcutaneous injection. For laboratory monitoring, it is usually not required due to the predictable pharmacokinetics. When needed, it is monitored by chromogenic anti-10A heparin assay. For therapeutic range, if you give a 2.5 milligram dose, the range is going to be 0.2 to 0.4 milligrams per milliliter, where if they give a higher dose at 7.5 milligrams, it would be 0.5 to 1.5 milligram per milliliter. The PTT is not sensitive to the effect of the pentasaccharide therapy because although it reacts with antithrombin to inhibit factor 10A, it does not inhibit thrombin or factor 9A, 11A, or 12A. These are some examples of direct-acting oral anticoagulants that can be given to patients. As far as laboratory effects, it can prolong both the PT and PTT, but routine monitoring is generally not required for these. As far as a clinical advantage, it's an attractive alternative to warfarin and low molecular weight heparin injections. The oral administration improves convenience and patient compliance, and it also has predictable pharmacokinetics that reduce the need for frequent monitoring. These are some examples of direct thrombin inhibitor therapies. So the mode of administration, we have dabigatran, and that is an oral anticoagulant, where you have argotrobin, and is an intravenous. And then for laboratory monitoring, we have an activated clotting time, or the ACT test, that is used primarily during those high dose therapies like cardiac procedure. We also have an Ikarin clotting time, or an ECT, and this is a specific assay for monitoring thrombin inhibitor activity, since this is sensitive to DTIs. For measuring antiplatelet therapy, So we can use an intravenous glycoprotein 2B3A inhibitor. It works by binding to the alpha 2B beta 3 receptor sites on platelets. We're going to block the binding of fibrinogen and von Willebrand factor, and the result is a reduced platelet aggregation and prevention of that thrombus formation. For oral antiplatelet drugs, this is used to reduce incidence of arterial thrombosis. Common agents include aspirin. For laboratory monitoring, we can do aggregometry. This would be a measurement of platelet function in response to that antiplatelet therapy. It can be used to assess efficacy and help guide therapy adjustments.